All right, I just want to thank everybody for being here today with us. My name is Michael Jones, and I am the current president of the Arkansas Counseling Association. And I just want to thank you for taking out some time today to be a part of our first webinar series that we're doing this month. We're focusing on Minority Mental Health Month, and we're so excited about the different webinars we'll be doing this month. Today, we have Dr. Rachel Hennessy. She is going to be doing talk today to us about the LGBTQ population, also intersectionality with that. And so I'm very excited about her being here today with us and being able to talk to us about this topic. So if you do have any questions or anything, feel free to type questions in the chat box, and that way we'll try to address those towards the end of the time. But without further ado, I'm going to give the time to Dr. Hennessy.
Thank you very much. Are you able to hear me okay?
Yes.
I'm going to be using my phone for the audio, so you might want to pin my screen with my image on it, and that way when I'm sharing my PowerPoint, it will stay up on your screen. So I'm going to go ahead and try to share that now.
Is everyone able to see?
Sorry about the technical difficulties. I hope you can see my screen now. So thank you very much for inviting me. I was really honored to be asked to give this presentation to the Arkansas Counseling Association and its members. And today what I'll be talking about is affirmative intersectional counseling when working with LGBTQI+ clients. So just to give you a brief introduction of me and my interest in this area, I do have my PhD in counseling and counselor ed from the University of Florida. And additionally, I have my master's and EDS in mental health counseling from the same program there at UF. It was of great interest to me to work in this area in terms of looking at LGBTQ affirmative counseling from an intersectional perspective. And so I chose to also seek out a couple of graduate certificates to further develop my knowledge in these areas. So I do have a graduate certificate from the Center for Sexualities, Gender, and Women's Studies Research, as well as a grad certificate that I'm finishing up this summer in LGBT health policy and practice from George Washington University. So I have been working in the area of LGBTQ affirmative counseling for about 9 years since I started my thesis research as a master's student. And it's also an area that is of particular interest to me personally, identifying as a part of the community. And it's just something that has been really meaningful to me throughout my life. So in the hour today, there are a few goals that I hope to achieve. First off, I hope that you'll go away from this webinar with an understanding of what it means to provide affirmative counseling and why it's really important for counselors to be specifically affirmative with this population. Secondarily, I hope that you will leave here with an understanding of how intersectionality as a theory does provide a justice-based framework that we can use for addressing the existing inequities, such as mental health disparities for LGBTQ people. The final goal that I hope we will achieve today is that you will leave with an understanding of why an affirmative intersectional framework is important for working with LGBTQI clients. There are just a few constructs I want to cover briefly just to be sure that we're on the same page throughout the conversation. And some of these might be familiar to you already, but some really important constructs to be aware of are the concept of affectional orientation, gender, and biological sex, and how these are all different. So some of you might already be familiar with this term of affectional orientation. Now, this is a more recent term that's used instead of what we used to call sexual orientation. So the Human Rights Campaign defines sexual orientation as an inherent or immutable enduring emotional, romantic, or sexual attraction to other people. Affectional orientation is becoming used more often, and it's often preferred because it is more inclusive of love, commitment, romance, and other parts of relationships, rather than focusing specifically on sexual behaviors. So this also makes it more inclusive for people who identify as asexual, who might have romantic feelings and relationships without any sexual behaviors. Another important concept is the concept of gender. Gender is a very complicated construct to look at because of the fact that it is a social construction, and there are a variety of different ways that people define and think about gender. In a lot of Western societies, it is often believed to be a binary, often thinking about male and female or men and women, because of the fact that in these types of societies, it's often conflated with biological sex characteristics, meaning that often when a baby is born, the doctor and parents look at those biological sex characteristics and make a determination of gender. However, there are a lot of cultures that currently exist and have existed over time that have non-binary perspectives, as well as various different categories other than just men and women or boy and girl. Now, gender relations are very complex. They're very deeply entrenched in terms of what types of gender roles and expectations exist. And so in that way, they really do shape all facets of our experiences. Now, biological sex is different from gender. So this is also a designation assigned at birth, typically based on physical characteristics. So that could be looking at genitalia, chromosomes, or hormones. This also is often treated as a binary and sometimes is confused with gender. However, there actually are more than one type of biological sex as well. So additionally, biological sex is often thought of as a binary when it actually is not. So some of you might be familiar already with intersex identities, but it's important to keep in mind that biological sex does not determine gender identity, and the biological sex itself is also not a binary. There are many different chromosomal and hormonal variations that can fall into the category of what is known as intersex characteristics. And according to Algebetic, or recently known as SAGE, the amount of people who have intersex characteristics is commonly reported as being as many as 1 in 2,000. So this is not something that's incredibly rare. And this is a very interesting resource. If you'd like to look at this, I can send the link out later, but this is from PBS. And what they said is that on nearly every continent and for all of recorded history, thriving cultures have recognized, revered, and integrated more than 2 genders. In fact, these terms such as transgender and gay are very new constructs in terms of human history. So the binary perspective, though very deeply entrenched in many Western cultures, has not even been the norm for a lot of history. So I just wanted to cover those constructs briefly, just in case anyone wasn't familiar, and for you to keep in mind as we move forward in the conversation. So what we'll talk about first is why it's necessary to specify an affirmative approach for working with LGBTQI people. And some people might sometimes think counseling already by nature is affirmative. And so why do we need to call it affirmative when we work with this group? But there is a very specific reason for that. So historically, LGBTQI+ identities have really been marginalized within Western psychological professions. Oftentimes, identities related to gender and affectional orientation were conflated as being the same thing. So for example, there's a lot of psychology from the beginning of the field that talked about men who were gay also necessarily wanting to be women or having female hormones or chromosomes and different things like that. So there was a lot of conflation of orientation and gender. Additionally, throughout history, there have been various models of LGBTQI identities being either mental illnesses, being immoral, or being somehow developmentally deficient. So maybe someone had a bad experience with their mother and that therefore led them to have a particular orientation. So a lot of the history, even within the counseling field, has been very marginalizing and very negative. There have been multiple different diagnoses related to orientation and gender identity. These have changed a lot over time, sometimes becoming more covert. However, because of these types of diagnoses, people in these categories could be labeled as being mentally ill or in need of some type of a cure. Now, this has led to some very harmful practices such as conversion therapy. Now, in the last decade or so, there has been quite an incredible increase in visibility and acceptance. And this is both in the US society in general, but also within the counseling field. We've seen a lot of changes. So affirmative approaches have been endorsed very specifically by both APA and ACA for working with LGBTQ people. However, despite a lot of progress, there are still a lot of inequalities, including mental health disparities that exist across the lifespan. So LGBTQI people are at a higher risk for things like depression, anxiety, substance misuse, and suicidality. Some very concerning things that we're seeing still are things like backlash to progress, so regressive policies at state levels or university levels, kind of pushing back against some of the progress that's been made. We've seen a lot of conversation about value-based conflicts in counseling, conversations about whether someone can refuse to work with an LGBTQ person based on their personal beliefs, for example. Although a lot of states, cities, and counties have passed bans on conversion therapy for use with minors, it's still legal in a lot of states, and it's still legal practically everywhere for use with adults. Most of the bans are only for working with people 17 or younger. And that's despite the fact that ACA, APA, and numerous other organizations have come out in saying that conversion therapy is in fact very, very harmful. There is unfortunately still a lack of a standardized affirmative training to really address the effects that stigma have had on LGBTQ people throughout society, but also specifically negative events that people might have experienced within therapy. Another major concern is the need for intersectionality as a systemic approach that acknowledges diverse experiences of LGBTQ people. So really being able to acknowledge that this is a wide variety of people, that LGBTQ people exist in every culture, and that they're not a monolithic group with one shared experience. It's really important to note that numerous research studies have shown the existence of mental health disparities for LGBTQ people, and this is something that's really urgently needing to be addressed by counselors. Again, LGBTQ people unfortunately are at an increased risk for depression, anxiety, suicidality, substance abuse, self-injuring behaviors, hypervigilance and trauma responses. And that's just psychological disparities. We also see social disparities like bullying, victimization, homelessness. So there are still a lot of areas in which oppression and marginalization exists for LGBTQ people, despite that a lot of progress has been made. So these types of disparities can actually be influenced and exacerbated by the systems that we work in. There can be a lot of different barriers to care. A lot of times LGBTQ people might have negative experiences within the mental health system. Maybe they've had a negative experience with a counselor in the past. Even if it was unintentional, maybe the counselor didn't mean to do any harm or had any overt biases, but maybe just didn't have the necessary training to understand that person's experience. And then certainly if someone has past experiences with conversion therapy, that can really increase the likelihood of them having distress, because conversion has been linked to increases in distress, depression, suicidality, and substance abuse. So when we think about these mental health disparities, it's really important that we frame it within the scope of looking at the impact of stigma. So acknowledging that there's nothing about having an LGBTQI+ identity itself that is connected to having a higher likelihood of mental health issues or concerns, but in fact, it's the stigma that people face that leads to these higher rates. So it's really important when we think about working with LGBTQI clients that we think about the concerns that they may have within the context of history and social and political climates. So to do that, we have to think very clearly about what stigma is. So Hatzenbuehler and colleagues define stigma as the co-occurrence of labeling, stereotyping, separation, status loss, and discrimination in a context in which power is exercised. And I think that this is a really helpful definition for stigma because it really points out that stigma is not something that just exists in the atmosphere. It really is exercised by the people who have power, because there's a way that using this stigma against other people increases their privilege or maintains their privilege. So stigma can affect people based on many different social positions or identities. We can think about how stigma affects people because of their race, their affectional orientation, their ability or whether they have a mental health diagnosis, gender identity, and more. So the way that people are stigmatized also in some way determines their social positions and social power. So as Hatzenbuehler and colleagues stated, those with power often use stigma for several different purposes. One is keeping people down or being able to exploit people. One is keeping people in, or norm enforcement. So this is certainly something we can see when we think about gender rules, right? That if someone steps outside of a norm in terms of what's expected of them from the gender they were assigned, that there might be some type of a punishment. And keeping people away, or disease avoidance. So we can think of some examples of how this plays out in society. For example, if we think about the epidemic of Black women, of Black transgender women who are murdered and victimized in the United States, we can see how there's both a norm enforcement and an exploitation that takes place. And there's sort of a double stigma, because first, unfortunately, there's this violence that occurs, but then what we often see after the fact is that people's identities are then not respected. So a newspaper or a police officer might misgender them. So we can see that stigma has very real effects, and it's not something that is abstract. There are a lot of potential outcomes such as exclusion, discrimination, segregation, increased stress, and also that can lead to diminished SES. So there are three different theories that we can talk about just briefly for the sake of time to help us understand how stigma is directly related to these mental health disparities. So first we'll look at minority stress theory, which can help us understand how stigma affects an individual. Then we'll look a little bit at fundamental cause theory, which can help us understand how stigma creates health disparities for populations that are marginalized. And then we'll talk a little bit about intersectionality. Now, intersectionality can help us to understand how there are interlocking systems of power that create inequities for people and how people experience those differently based on their variety of interlocking identities. Intersectionality is important because it helps us to understand how to analyze the power structures themselves rather than looking just at the experiences of individuals. So Meyer's minority stress theory is a conceptual framework that was created for understanding how stressors related to minority status are then related to the increased risk for these negative psychological outcomes. It was originally created just looking at affectional orientation, but there has been research later that included gender identity. And so this is an image that hopefully can help you understand this theory, but there are two different types of processes. So first, there's what Meyer called a distal process. Now this is an objective event. For example, an experience of discrimination could be an event that occurs. But what occurs from that event are then proximal processes. And these are what can lead to a person experiencing psychological distress because of stigma. So the distal process can lead to subjective perception, which can then lead to an expectation of external stressful events. So basically, if someone experiences discrimination, then they might end up having an expectation that they could experience it again. So they might have a fear response, or they might have to start avoiding certain places. They might miss out on opportunities because they're concerned that another negative event could happen. There's internalization of social prejudice and negative societal views. So you might have heard this called internalized homophobia or internalized heterosexism, but someone might end up having negative beliefs about themselves because of the objective event. And then the last proximal process that can lead to the mental health concerns would be feeling that one needs to conceal or hide their identity in order to stay safe, avoid punishment, or have equal opportunities. Now, Hendricks and Testa did expand this model to include transgender and gender nonconforming people, and those proximal stressors were very similar. So expectations of future rejection, a hypervigilance, concealment of identity, and again, that internalized stigma. So as counselors, we can think about how people's experiences of stigma or discrimination can be directly related to presenting concerns such as depression, anxiety, suicidal thoughts, or substance use. Now, fundamental cause theory takes us to the next level, moving beyond just individuals to look at how stigma can impact a community of people or a group of people. So they really developed this to look at health disparities from a structural perspective, because at the time, back in the 90s, and still in a lot of cases today, public health was very focused on looking at individual behaviors as both the cause and the solution. But what Lincoln Salon said that was different is that social conditions are the fundamental cause of health disparities when we look at any condition that's either preventable or treatable. So social conditions put some people at a higher risk of risk. People who have more power in society are more likely to have access to protective factors, preventative measures and preventative education, as well as treatments available. And so this was created to look at health disparities, but it certainly can be used to look at mental health disparities as well. Now in 2013, Hatzenbuehler, Salon, and Link actually identified stigma as the fundamental cause of all health disparities. So I know that was a lot of information that we could only cover really briefly, but I hope that it gives you a framework for understanding why LGBTQI+ affirmative counseling is necessary and why it might be a little bit different from counseling with other populations. So to really address historical oppression, we do need to take an actively affirmative approach when working with LGBTQI people. So what this means is going beyond the concepts of being tolerant or just accepting of identities to really rejecting heteronormative, heterosexist, and transphobic views. Affirmative counseling really affirms LGBTQI identities as being normal, healthy, and legitimate, and therefore not pathological, immoral, or even abnormal. Affirmative counseling also acknowledges that mental health disparities are related to social stigma and not LGBTQI identities themselves. And this is really, really important. So LGBTQI health disparities are not related to the identity, but they're related to those social conditions. Additionally, affirmative counseling is culture-centered and culturally responsive, acknowledging that LGBTQI+ people exist in all cultures, all races, and there's just not going to be one universal experience. So we have to be really careful to really take an intersectional perspective, acknowledging how different intersecting identities lead to very different experiences. LGBTQI affirmative counseling also really utilizes the strengths and resiliencies of individuals and communities. And this is really important because as we talked about the history of LGBTQI marginalization within psychological fields, it's important to note that the changes that occurred and the progress that has been made was due to people. People were activists, people advocated for changes. And it was very hard, and it was really in the face of a lot of danger oftentimes for people to have to come out and say in the 70s that homosexuality should not be a diagnosis in the DSM. And so there's a really deep history of activism, and it's really important to be able to understand that and really honor that. And additionally, affirmative counseling does require active efforts to address systemic barriers to care. So in addition to the work that we do with clients, we can also think about what barriers still exist and what we can do as advocates. So this is a quote, and this is from Bedell and Whitman. LGB affirmative counseling rejects biased, heteronormative, and heterosexist notions that LGB sexual orientations are representative of mental disorders, inferior status, immorality, or social deviancy. Instead, it affirms LGB people have a sexual orientation that is normal, healthy, and legitimate. As such, the disproportionate levels of mental health problems found among LGB people are not resultant of having a minority sexual orientation, but linked to the stressful and detrimental effects of LGBT prejudice, discrimination, and stigmatization. With this foundational understanding, competent LGBT affirmative counselors examine and advance their attitudinal awareness, develop a comprehensive knowledge of LGBT issues, and utilize ethical, professionally based, and non-discriminatory counseling skills. Now, Singh and Dickey also have defined affirmative counseling with transgender and gender nonconforming people, stating that it is counseling that is culturally relevant and culturally responsive to multiple different social identities. It addresses the influence of social inequities. It enhances client resilience and coping. It includes advocacy to reduce systemic barriers, and it leverages client strengths. So next, what I'm going to talk about is intersectionality. And this is a very complex theory with a vast history, and so I can't do it much justice in this time frame, but what I do want to do is talk a little bit about the foundations of it, and then I can provide some resources for follow-up for those of you who would like to know more about it. But intersectionality is really an analytical tool for critical inquiry of power structures. So it's really about looking at systems of power and oppression that are interlocking. For example, things like racism, heterosexism, ableism, classism. So intersectionality is not just about individuals having identities that are interlocking, but how those different identities are then influenced by these systems of power that are also interlocking. So people and groups are impacted by the systems in different ways based on the identities that they have. So for example, on an individual level as a counselor, we can understand that a person's identities cannot be separated and viewed individually because they are mutually constructed. So for example, if working with a white cisgender gay man from a large city, we would have a very different set of experiences than if we were working with a Black transgender woman from a rural area. And so from the individual level, we just have to be careful to understand that all these different identities and the way that people are impacted by them are going to create an experience that just simply cannot be universalized. At the structural level, it's important to think about how these different systems cannot be separated and addressed individually, because those systems of power are also mutually constructed to provide privilege to a specific group of people. So the development of intersectionality theory has been strongly grounded in Black feminist theory, as well as Chicana mestiza and what's often called third world feminist theory. Sometimes the umbrella term for this is women of color feminism, but there have been many, many people who have written about intersectionality going as far back as the 1800s and the speech by Sojourner Truth, Ain't I a Woman? She is often cited as one of the first people to talk about intersectionality and how the experience of being a woman was not universal because there were other identities and power structures that were connected. So the opposite of an intersectional approach would be what's often called a single axis approach. So if we were to look at LGBTQI counseling without considering things like race, without considering class, nationality, ethnicity, then we would be using a single axis approach, looking at just one type of identity. Now, what happens in a single axis approach is that those who have the most privilege in that group will end up becoming centered or privileged. So even within an LGBTQI space, if it's not intersectional, then people who are white, cisgender, upper class, and able-bodied would still have more privilege even within that group. Another problem with a single axis approach is that it creates this false concept of a universal experience, which marginalizes or erases people who do not fit that prototype. So as we go into thinking about LGBTQI+ affirmative counseling from this intersectional perspective, we'll be thinking about the identities that clients have, as well as ways that we can start addressing some of the power structures that are leading to the mental health disparities. So intersectionality is an approach for addressing the mental health inequities that still exist even today for LGBTQI+ people. And using intersectionality really illustrates the potential to explore complex phenomena and outcomes in order to really improve health equity and social justice. . So a counselor who practices from this perspective would have knowledge and awareness of how oppressive systems impact people in different ways based on their social locations, which is another way of saying identities. When we talk about social locations rather than identities, though, we're seeing it more from the structural perspective, whereas talking about identities can often become the individual perspective. So I use these interchangeably, but social locations talks more about how people based on identities are placed within a power structure. Counselors using this affirmative intersectional approach would also need to have knowledge and awareness of their own biases, as well as any types of implicit reference points. And so what that means is having stereotypes or having prototypes. So we have to be really careful, even as we're learning about the history and we're learning about people's experiences, that we don't automatically apply that to all people. There are certainly going to be LGBTQI+ people who come in with counseling concerns that are not related to their identities. So being sure that we don't automatically assume what people are coming in for. Additionally, counselors would have knowledge and awareness of biases and injustices, not just within themselves, but also within their workplaces and within the counseling field in general. And so this means really understanding the history of psychology, the history of counseling, and knowing that if a client comes in and maybe they're hesitant to talk to you, that instead of going to the mindset of, oh, this client is resistant, that we can instead go to the mindset of knowing the counseling field has only recently started to be affirmative, and this person might have very legitimate reasons to be hesitant. So kind of shifting that perspective. So similar to elements of feminist counseling theory and multicultural counseling theory, an intersectional and affirmative practice would really place emphasis on relational and structural elements. So looking at the counseling relationship as well as the social implications, rather than the intrapsychic. So rather than just looking at an individual and what's going on in their brain or what's going on with their behaviors. So we kind of want to look at shifting away from that sort of individualized medical model. So there are a few things that would take place in counseling from this approach. So one would be actually engaging in structural analyses of power with your clients, actually having conversations about these types of things with them directly, talking about the impact of systems, talking about how their different intersecting identities have impacted their experiences, as well as working both on your own and with clients, if they're open to it, on efforts and actions to try to actually address and transform the oppressive system. So kind of moving beyond just teaching ways to cope with oppression and looking at ways that we as professionals or in relationship with clients can actually try to change those things. This perspective would also incorporate knowledge and discussions of social causes and contextual implications. So if you think back to something like minority stress theory, and you think about, for example, the internalized heterosexist beliefs, an example could be that you have a client who has those types of internalized feelings where they come in with depression, anxiety, maybe substance abuse concerns, and they think that they are the problem. So being able to kind of guide them in thinking about how other parts of their lives, how other experiences and social causes could also be contributing. So trying to move people into a deeper understanding and shifting away from some of that self-blame. Another important piece is this critical praxis. And so praxis being that cycle of theory and practice and how we learn and develop over time. So the more that you engage in an affirmative intersectional approach, the more that you then learn and reflect on it, and it develops with you over time. What's also important is then the awareness of biases in yourself as well as within the profession, and the ability to be affirming of identities and provide culturally competent and responsive counseling services. So here are some very specific areas where an LGBTQI affirmative intersectional approach can be used as a framework to guide your thinking and to guide how you're conceptualizing your client. So for these questions that I'm about to ask you, these are just reflective questions. I did provide a handout that you'll get by email if you haven't already that actually has these questions on it so that you can think on it more. But for example, when we think about assessment and diagnosis from this perspective, we want to think about these things. What was the theoretical grounding for the development of the assessment that we're using? Or how was this diagnosis developed? What is the belief system behind it? When we look at using an assessment, we have to consider whether social and political factors were considered in the development of the clinical categories. We want to think about whether the purposes of the assessment, as well as the possible consequences of its outcome, are actually made transparent for the client, whether we're capable of talking with clients about how these results might impact them. It's important when looking at assessment and diagnoses to think about what population was used for norming. So who was the pilot group when these different assessments or diagnoses were created. And then we also want to think about whether research on this particular assessment or this particular diagnosis shows certain groups being underrepresented or overrepresented in the data. And if so, is it possible to identify whether that is due to some type of a disparity or whether it's due to some type of a bias in the assessment criteria? And so one example of this could be when we think about things like IQ testing, that a lot of times the questions that are asked are very biased towards people of a Western white culture. So that could be an example of an assessment that is biased in and of itself. So we want to think about whether the results seem to privilege or marginalize specific groups of people. And then also think about whether we've done the work to really develop the knowledge to discuss these areas with clients openly and directly. So the next area is treatment planning and interventions. So from this perspective, the affirmative intersectional perspective, these are the kinds of things we want to think about. First, are your client's goals going to be the priority in your treatment planning and your choice of interventions? And if not, then think about what your priority is. It could be insurance, it could be loyalty to a specific theory, but really challenge yourself to think about what you're placing as a priority when you do treatment planning and when you choose what to work on with your clients. Are the goals developed and the interventions used culturally appropriate, and are they viewed as helpful by the client? Are the impacts of social, political, and environmental factors discussed openly with your clients, and are they included in the treatment plan? Are you really open to receiving feedback from clients about what they find helpful and unhelpful? And have you created a relationship with them where the power is balanced enough that they would feel comfortable letting you know? Are you aware of your own biases and beliefs that can affect the counseling relationship as well as the choices that you make? And this one's really important. Are you able to learn from the client about their particular experiences while at the same time educating yourself on historical, social, and cultural factors? So what this means is being able to have an understanding of the history and culture and societal issues that might be impacting your client without stereotyping and projecting that onto them, because it's possible that it's not their experience. For example, if you have a client who is transgender, you don't want to automatically assume that they have gender dysphoria or that they have a family that's not supportive. They might be coming in because they have a diagnosis of bipolar and they're perfectly comfortable with their gender identity and their family is very accepting. So being able to sort of navigate the waters of knowing what are the things that could be factors, but also being able to learn from the client and not just assuming. Now, we additionally want to think a lot about advocacy and activism when we come from an affirmative and intersectional perspective. So you want to think about whether there are areas where advocacy is needed in your workplace, maybe in your professional association, or even within the community where you work. Maybe there's something at the state, county, or city level. For example, maybe there's not a conversion therapy ban yet in your area that you might want to work on. Are you able to identify ways that you can advocate in these areas to improve equity and justice for your clients? And have you learned from those who are the most affected about what they would find helpful? So being sure that we're listening to people, that we're knowing when to center our own voice and when not to, which leads to the next point of, do you feel empowered to advocate? And are you able to know when it's important for you to center your voice, maybe as a professional or because of your own identification with the community? And when it's important to just amplify the voices of others who are better able to say what they would find helpful. And then lastly, advocacy can be very hard work. So thinking about whether you've found yourself a support system or collaborators, people that you work together with. And this can include your clients as well. So when we think about LGBTQI plus affirmative intersectionality, we want to think about, rather than focusing primarily on individual coping skills for dealing with oppression, instead working to create this egalitarian relationship with clients and talking with them about these things openly. So creating the relationship and the space where clients can analyze systems of power with you, where you can have open discussions about power differentials in relationships, including the counseling relationship, so acknowledging where you might have privilege there. Being able to talk honestly about the role that mental health professions have had in promoting and maintaining oppressive social systems, not only for LGBTQ plus people, but for other people as well. Being able to discuss the impact that stigma and marginalization can have on mental health and relational health. And being able to engage in social justice advocacy at many different levels. So in an agency, in a school, maybe through public policy, as a part of ACA, finding different ways that you can have your voice heard and that you can amplify the voices of others. And I did want to go over just briefly a case study. I know we don't have time to talk about it as a group, but just to kind of highlight what this might look like. This is kind of an example of what can happen when someone uses an approach that is not affirmative and intersectional. So consider this. You're shadowing another counseling intern at your clinical site. This intern is white, about 23 years old, and identifies as queer. And you're sitting in with the intern who's working with a 68-year-old African-American client who is considering moving into a seniors community with his husband. He's worried about how other residents might respond to them if they move in there. Now, this intern replies that they get it because they are also queer. And after this, the client becomes very quiet. The intern then tells you afterwards that the client has been resistant to counseling. So think for just a few moments about what might have contributed to the client becoming quiet, and what concerns arise for you from an affirmative intersectional view. And I think we have enough time that I could read one or two comments from the chat if you'd like to share there.
We could also give people some time to respond with their own voice if you'd like, Rachel. If you could raise your hand if you'd like to speak, then I could unmute you and we can have more of a dynamic discussion.
That would be wonderful if there's time for it.
Looks like we've got some people doing both. Janet has raised her hand to speak. I'm going to allow you to talk, Janet. Okay, Janet, why don't you share?
I'm wondering if the client, can you hear me?
We can.
Yes.
If that client probably experienced a great deal more in his lifetime, being he is intersectionally, he is both Black and gay. He may have experienced things that the white 23-year-old, he's younger, he's white, he has privileges that this gentleman might not have had. So when he says, I get it, he might feel like, no, you really don't.
Yeah, exactly. So having a very different experience of life for many different reasons, it could be seen as very dismissive for the intern to say that they get it, rather than asking questions and exploring that more.
We had a number of individuals in the chat who kind of echoed those same sentiments and recognitions with this case study client, Paul Booker. I hope you pronounced your name correctly. Several factors, with one being the use of the word queer, which may be offensive to someone older.
Exactly, and so that's a really great example. So the word queer is something that for a lot of younger people has been somewhat reclaimed. People feel very proud to use that word as an identifier, and that word historically was a slur, and again, is considered to be very offensive to many people of other generations. So really thinking about being incredibly careful to understand the terminology and the history that is comfortable to clients rather than what we might consider to be acceptable by different standards.
Carla Gentry also recognized the age gap, made the session about themselves rather than hearing the client with their comment. Kelly also recognized the intern is young and inexperienced to be this forthcoming with the gentleman. I think this gentleman might have felt that his concerns weren't being heard. And then Dominique White also recognized just the comment, I get it, probably shut the client down because in many ways, the counselor might not get it. This is an African-American man from an older generation who has probably had many different experiences than the young intern.
Definitely, these are all really great points. And I think one of the reasons I find this particular case study to be helpful when looking at the intersectional perspective is that this intern, as a part of the LGBTQI+ community, may very well have thought that they are automatically affirmative. And yet, because they're missing that intersectional piece, they're damaging the relationship with this client by not recognizing these other experiences and other identities play such a major role.
And I don't see any more comments or hands. So, Rachel, I don't know if you are wanting to proceed further.
Yes, thank you. Thank you all for chiming in. And so just as a brief summary as we come up on the hour, affirmative intersectional counseling is a systemic approach to addressing the needs of individual clients and the structures that created and maintain mental health inequities for LGBTQI+ people. So again, it really focuses on structural analyses of power impacts of systems on how people experience their different intersecting identities, as well as efforts and actions to address and transform those systems. So when a client comes in and they've had experiences of marginalization, of oppression, that we're certainly going to talk with them about decreasing their distress. We're going to talk with them about what's helpful for them as individuals, what's helpful for them in their relationships and their communities. But we have to also focus our own time on really trying to address those areas so that the oppressive systems do not continue, so that we're not just teaching people how to cope with oppressive systems as if they're just inevitable. Again, knowledge and discussions of social causes and these contextual implications are really important. Being able to actually be open and honest with clients and talk about these different systems directly. Moving beyond just teaching ways to cope and really showing that we understand how these different experiences could be impacting them as individuals and could be impacting, their opportunities in life as well as their wellness. It's really important as counselors to have awareness of biases in the self, but I think it's also really important to have the awareness of biases that occur in systems and professions. And I think that we might be hesitant to be overly critical of the counseling profession because it's something we believe in strongly, but really knowing that if we can critique it and we can try to make things better, that's because we care about the profession, because we care about our clients. And so trying to feel some comfort with being aware of some of the histories that are more negative and some of the things that still need to get fixed. And then lastly, having cultural competence in addition to affirming LGBTQI+ identities. So knowing that LGBTQI+ people are not a monolithic group, there's not a universal experience, and so we have to have the cultural competence piece as well. And so I'm not sure if there's time for questions or not. I have time to stay if others want to, but thank you so much for inviting me. It was really an honor to be a part of this series. Thank you to the Arkansas Counseling Association for inviting me. And should you want to reach out, I do have my email and my website here.
Rachel, while we have you in just a few more minutes left, can you recommend a go-to book for an intern in training who is just starting to learn about this community?
A go-to book related to the community of LGBTQI+ people?
Yes, and if you have a recommendation for learning about affirmative practices, I think that could also be beneficial to this intern.
Absolutely. So there's a book from 2017. I'm going to try to find it. It's Misty Ginicola's book. And I don't have my reference page up, so I don't remember the exact title of it. But if I can get back to her name.
I can help you with that, Rachel. It's Affirmative
Counseling. I can tell you it's
with LGBTQI+ people. It's by Wiley, it's by Misty Ginicola, Cherry Smith, and Joel Fillmore. All amazing individuals, and I'll share the Amazon link. Not saying you have to buy from Amazon, but it's shared in the chat for you all. And you all do get 1 hour of CEU from this. Please be sure to complete the post survey. It will pop up on your screen as we close out of this webinar. Do we have more questions? All right, I see a hand has been raised. Just got to find it, by Melinda. I'm going to allow you to talk, Melinda, and unmute you. Okay, Melinda, go ahead.
Would we be able to get a copy of your paper when it is completed and approved?
I'm sorry, say that again.
Would we be able to obtain a copy of your research paper when it is completed and approved?
Yes, I could share a link to one that's been published already, a paper with Dr. Christian Jan that we worked on together. I have a few others in the works, but I could certainly find you the link to that one and have it.
Thank you.
Would it be? Yeah, certainly. And I would add, you know, for introductory books, there's a book that's simply called Intersectionality. It's by Collins and Bilge, and it's an amazing, amazing resource with tons of examples of intersectionality in practice and advocacy work. So I would highly recommend that one as well. Patricia Hill Collins. Thank you.
I second this as a resource. Other questions, comments? Okay, well, I want to thank you all for your time. Rachel, thank you so much for coming and sharing your expertise with us. We greatly appreciate you as a start to recognizing and spreading awareness and knowledge about treating marginalized and vulnerable populations. Please remember to complete the post survey. That'll help us to make sure that you get your CEUs. Reach out to us at arcounseling.org if you have any more questions, and you see Rachel's contact information on the screen. I hope you all have a great rest of the evening, and we hope to see you at our next webinar series on treating Black and African American populations, and that'll be next week, so be on the lookout for that as well.